All right, everybody. So today we're going to cover Chapter 8 on health promotion and health communication. We're going to talk about different theories that go along with that, and then talk about some strategies, some guiding principles, and also some different options for that communication piece and presentation. So we have our learning objectives at the beginning. You can scroll through those on your own time. So of course, whenever we're talking about health promotion, we want to know what that is, right? So the WHO defines health promotion as the process of empowering and enabling people and communities to increase their control over various determinants of health and therefore to improve their own health, right? So I want you to take note that health promotion is geared towards individual people and also communities, right? So health promotion can fall all along that line of individual patients and also communities as a whole. And we want to help give people and communities control over those determinants of health, right? So some of those things that affect their health so that they can improve their own health. So when we're looking at health promotion, we are not just looking at attitudes and knowledge, right? But we're really looking at the role of the behaviors. So those things that are happening day in and day out, the things that maybe are also missing, right? The behaviors that people have, or maybe the behaviors that they're missing, the behaviors that they don't have access to. And so we're not just looking at the individual behavior of what we're going to talk about, because this is community dental health, but we're going to look at that wide range of social and environmental interventions. And health promotion really goes beyond that educational piece, right? It's not just telling patients things and informing them, but also linking oral health to other health issues. So health promotion isn't just always patient-based. Sometimes you're doing health promotion in the sense of policy change. So you're talking to maybe legislation, or you're talking in stakeholder groups with other people that don't know anything about oral health. They want to know, or maybe you're going to make them want to know about oral health problems and those links to other health issues, right? So global or oral health promotion isn't just that provider to patient type of dynamic. It can be provider to provider, provider to organizations. The list goes on. So when we're looking about oral health promotion, we all start looking at that global health promotion, right? So we have the Ottawa Charter. This was created back in 1986. And this charter really developed 3 basic health promotion strategies of advocacy for health, enabling people to achieve their full health potential, and then mediating different societal interests in the pursuit of health, right? And we've talked about before how sometimes we have to be able to assess what the society or the community's interests or their perceptions are. So sometimes part of our oral health promotion is helping to change some of those societal norms, right? Like in some areas, you'll find that it can be the norm that people just expect that they will lose their teeth as they get older. That's what's happened to their friends and family that they know. That's what's happened with their neighbor, the people they work with, and so on. But we know as oral health providers that just losing your teeth is not supposed to just be part of the aging process, right? And there are behavior changes that we can implement and environmental changes and things like that that can help decrease something like tooth loss. So when we're looking at the Ottawa Charter and those 3 strategies, they also created 5 action steps. And these are action steps that we can use in lots of scenarios, not just global settings, but in local and even tighter community settings, statewide community settings, national settings, and so on. So we want to look at building healthy public policy, creating supportive environments for health, strengthening community action for health, developing health management skills, and then reorient health services. So we can give, providers incentives for like keeping people healthy and well. And sometimes that can be done even through things. There's talk sometimes of incentives like through reimbursement, right, to a healthcare provider. Or sometimes there are incentives for that reorient kind of health services kind of category of not being a smoker. Maybe you have a reduction in your costs, or you have better healthcare coverage, right? They'll cover more things, or they won't cover less if you have a behavior that's known to increase your risk or decrease your health. So there are lots of examples. So when you're looking at these 5 action steps, think of other examples, right, of building healthy public policy and things like that. Like, what are some examples that you can think of that fall into these 5 action steps? These are action steps that you can use in helping to think about programs that you want to create next semester also. So whenever we're talking about these strategies and health promotion, there are theories that are related to health promotion, right? So our theories help us think in a more broad sense sometimes, and so we can interpret those health problems, right? Because it's not just as simple as saying like, well, you have perio, or well, you have cavities. Or if you're looking at a community of saying, well, this community seems to have a high risk of decay, right? Or they have a high rate of decay. Well, we want to analyze and interpret why. Like, what's the connection here? Why maybe there are systemic reasons that this is happening, right? We're going to look at those variables. We talked about those different variables, right? Independent, dependent variables in chapter 7, whenever we were looking at research. So you're kind of taking some of that research mindset, but you aren't necessarily completing research, but you're using that research and analyzing mindset that you use with your patients individually on a daily basis to figure out what's going on with them, right? You're doing that critical thinking, and we're going to apply that to a broader community base. But these health promotion theories can also be taken and viewed on an individual basis also. So one thing is that dental hygienists, we tend to view oral health problems primarily as the patient's problem. And then we proceed to educate our patients, right? We tell them everything they need to know. But that approach is really generic, and it doesn't assess or validate the patient's point of view, their health beliefs. It doesn't consider their environment, their health literacy, cultural circumstances, influences, and different things like that that can affect their attitudes, their beliefs, their health practices, their daily routines, right? So what's something we talk about in clinic all the time that I'm always, especially if you've had me in clinic and we've done different practices and discussions about it, is motivational interviewing. So we're going to take that concept of motivational interviewing that you do with an individual patient, and we're going to take that to a community level, right? So we may have to do some things a little bit different than just talking individually to each patient. So we have different health promotion theories, right? And these help us, like some of our different research or data collection models, they help us give us things that we can look at and evaluate that look at behavior that leads to improved oral health that can be affected at 3 different levels. So when we're looking at health promotion theories, we have the intrapersonal level, which is individual, right? Intrapersonal is individual. We have interpersonal level, which is between people. And then we have the community level, which is institutional, organizational, policies, all of those really big, broad types of levels where we're reaching and affecting multiple people all at the same time. So if you look at this on like kind of a grouping, like your smaller circle is going to be the intrapersonal level for individual. Then you're going to expand, and with Outside of that is going to be your interpersonal, which is between people. Then you're going to expand that even more, which your bubble's going to get bigger, and that's your community level, right? So you have your community is your big all-encompassing circle. Then you bring in a little bit more. That's that interpersonal, between people. And then if you go even smaller, you've got all those little individual people within that interpersonal level, right? So we're going to talk about the different theories within each of these levels. And we're going to start with those individual levels first. And I forgot to delete one of my slides. So you can look at these in two formats. You can have them in a bulleted list and you can have them in a table. So we're going to talk about each of these individually. So in your book, there's also this table, 8-1, that also gives you a little more of a definition, right? For intrapersonal, interpersonal, and then community. And the community one is going to break it down into things like institutional factors, community factors, and policy, right? So the big thing though to remember is that intrapersonal is individual, one person. Interpersonal is between people like families, friends, peers, right? So if you think of all of you, each of you individually is an intrapersonal level, but as a group, you're interpersonal, right? Because you're between peers. And then if you take it to a community, right? If we're going to use this scenario I've used a few times this semester, we could take it to a community of all dental hygiene students, right? So you all don't know each other or have necessarily direct influences to each other, but there's institutional, there's community factors, and there's public policy that affect all of you across the state of Colorado, right? And then you can even take that bigger to be like nationally, because every dental hygiene program has to meet the same qualifications and level of education across the country. So the first one we're going to look at is intrapersonal, and this is a stages of change theory, or the trans-theoretical model, okay? So this is going to view change as a process or cycle that occurs over time rather than as a single event. Okay, so it's a little more longitudinal than just a single event. And this assumes that at any point in time, everyone is at a different stage of readiness to make those lifestyle changes, right? So it's also assuming that people actually cycle through various stages over time, depending on the behavior to be changed and whether the environment is supportive, right? And we've talked about over the course of the semester how our environment also impacts not just our behaviors, but our access to things, right? But those have impacts in our behavior. So we can go through cycles throughout our life over time. So stages of change theory is looking at kind of like the cycle of those various stages over time. So it's looking at a long timeline, not just a single event. So when we're looking at stages of change, there's different concepts, right? So we have pre-contemplation, contemplation, decision or determination, action, and maintenance. So during pre-contemplation is being unaware of a problem, not having thought about the change, right? We don't even know it exists. Now, think of this from an individual patient standpoint, because we are talking about individuals, right? How often have you had a patient that didn't even know they had a problem? Especially when it comes to perio or maybe even decay, right? They don't have any symptoms. So contemplation then cycle of this theory is thinking about change in the near future, right? So it's a thought. Pre-contemplation, you don't even know it's existing. Contemplation is you're now aware, and you're thinking about change. Decision/determination is making a plan to change. So you haven't implemented anything, you're aware, you've thought about it, and now you're thinking about making a plan to change, right? So you're making a plan. Action is actually implementing that specific action or plan. And then maintenance is continuing with that action or repeating the periodic recommended steps. Okay? And so this is a pretty easy theory to kind of relate back to with your patients. You can watch as a patient when you kind of walk them through maybe like their periodontal disease or that they have some cavities, and you see like that pre-contemplation, they may not know anything, right? And then you start to educate and have a conversation with them about their health. And you can see them thinking that process through, right? And then sometimes they start putting those dots together, which is always great because then your patient has more, they're more likely to actually move ahead. So an oral health example, right? We've talked about it just now. Is this the one they give as an example of like gingivitis, right? They start by increasing the awareness of a problem and they proceed. Then they may initiate a behavior change. They're planning first, right? To thinking about brushing effectively, using a rinse. And then they actually do that. And then they have that progress to maintaining that motivation. They may return in 3 months, or maybe it's 6 months, right? They're coming in, you're checking up with them to check on their progress also. So we have health messages and programs that should be matched to an individual's current stage of readiness to change. So when you talk about motivational interviewing, right, it's determining if the patient's even interested. And sometimes it's you plant that seed, right? You're in that contemplation phase. You set that contemplation phase. Sometimes we just have to wait in that cycle. So then we also have the health belief model, which is HBM. And again, we're still in intrapersonal, so individuals. This allows us to assess perceptions of how susceptible one is to a health risk and whether that person believes that recommended preventive behaviors will result in less susceptibility, right? So the primary hypothesis is that increased perception of severity and susceptibility to a disease results in an increased probability of taking action. So health belief model is one that as hygienists we use a lot because our hypothesis or goal also is that we assume if we tell our patients about the severity and the susceptibility to a result that they're going to want to take action, right? Now we know that we can't just make those assumptions. We have to talk this out with our patients. So when we're looking at the health belief model, again, there's kind of a process to this. And a lot of this is all through research and analysis and evaluating people. So the first concept is we have that perceived susceptibility, right? So this is the patient's opinion of their chances of getting a condition, right? And so that's where we have that high risk, low risk, moderate risk type of things that we talk about with patients sometimes. And if we tell them we have high risk, sometimes you can get someone's attention with that, right? So this is their own opinion of their chances of getting a condition. Then there's that perceived severity, which is their opinion of how serious a condition is and how consequential it is. Then we have perceived benefits, which is this person's opinion of how effective your advised actions are to reduce their risk or seriousness of impact, right? So one thing that comes to mind when I think of the health belief model, which is a struggle of lots of hygienists, is fluoride, right? And decay. So you can think through this process, right, of how this health belief model can affect people, right? If we're talking about fluoride, right? And you have somebody that's adverse to fluoride, they're kind of anti-fluoride, they have their opinions, right, of the advised action to reduce the risk. And we can take that even just to simple things as brushing their teeth, right? If somebody thinks it's worthwhile or not. Then we have those perceived barriers. And that's someone's opinions of the tangible and psychological costs of the advised action, right? What you've recommended, and that an actual costs are outweighed by the benefits. And this is a challenge that we run into all the time, right? Is kind of explaining sometimes even those long-term costs, and not even in like dollars costs, but like health costs. But sometimes we can use those dollar costs, which can speak louder to individuals than maybe their health. Or maybe we have to find out what's important to them, right? Maybe it's the look of something that's more costly to them than their health. And then we have cues to action, which are strategies to activate readiness. And then self-efficacy, which is confidence in one's ability to take action, right? So sometimes we have to help give confidence, not just to patients, but to ourselves too, right? That we know that we can help a patient take action, and then we can help a patient take action. So another example in the health belief model for an oral health example is something like oral cancer risk in somebody that smokes a pipe, right? So does this patient believe that limiting the use of the pipe would reduce their oral risk? Does this person believe that the effects of quitting pipe smoking are worse than the effects of oral cancer? Right? And when we read a question like that, we think, well, of course. But we also have to play into those factors, right? Like, is the patient interested in it? And we're looking at the patient's perception, not ours. And that can be a challenge. Does the person believe he can quit smoking the pipe? Right? That can be a big factor too, to taking action. Do they think they can actually do it? What type of support do they need to be successful? Right? So the model looks at perceived severity of a disease threat, the benefits of taking a particular health action, and then the barriers to completing that action. So we're looking at the perception, we're looking at the benefits, and we're looking at the barriers. So then the last one we're going to talk about that has, and this has to do with, we're done with intrapersonal. We're going to talk about interpersonal, which is from individual to individual, right? So like family members to family members, peers to peers, that kind of thing. So in the social learning theory, we're looking at how people learn primarily in 4 ways. So they remember and imitate observed behaviors of others. Vicarious experience, such as reading, viewing, or listening to various forms of mass media, social media, YouTube videos, things like that. Judgments voiced by others, such as testimony or promotions by experts, right? And judgments can be skewed, or they can be real, viable information. And then inferred knowledge, things that we just kind of pick up without really always knowing where that came from. So these are ways that in an interpersonal, so person to person, not just an individual, but these are ways that people learn in the 4 primary ways of learning. So when we're looking at this social learning theory, we have some concepts. Imagine that, go along with that, right? So we have the reciprocal determinism, which are behavior changes result from interaction between the person and the environment, right? So change is bidirectional. It goes one way. It can go back and forth from person and environment. Then we have behavioral capability, which is knowledge and skills to influence behavior. Expectations, right? Beliefs are likely a result of action. Self-efficacy, that confidence again, in ability to take action and to persist in action. Observational learning, which are beliefs based on observing others, like oneself, and or visible physical results. Observational learning, that's something to, you see that a lot, especially in social media now, right? Like observing others like oneself, and you're seeing those actual results, whether sometimes they may be real or not, right? Especially in today's digital age. And then reinforcement. So responses to a person's behavior that increase or decrease the chances of recurrence, right? So as providers, we can help with reinforcement by offering praise, maybe offering incentives within our office, and things like that. So when we're looking at that social learning theory in an oral health example, is if we consider helping a single mother to feel confident about toothbrushing for their young child by using techniques such as demonstration, right? That's something that we can do in the chair, watching a video, providing ongoing encouragement, and giving periodic feedback. So when the mother gains some confidence in the skills, she can assist the child care workers and other parents at the daycare center in learning these skills also, right? So you can see where that social learning theory, it can go from an individual to others, right? So when that mother is more confident about knowledge and performing something like toothbrushing, she then can actually pass that skill and knowledge on to someone else, right? So it's not necessarily coming just from a healthcare provider. We can transfer that from healthcare provider, from us, to the mother, and then that mother can then share that skill with not just one person, but she may also share that with other family members, share that with other child care individuals, other parents, right? Sharing that skill and that knowledge. Especially whenever you're talking about parents. A lot, because parents, they talk to each other sometimes to try to help, especially if they're struggling with something. And so they're supporting each other in that oral hygiene care, and that becomes then a daily activity. So we've talked about intrapersonal, which is individual. We've talked about interpersonal, which was our last one on the social learning theory. There's just one theory on that. And then we're going to talk about community organization theories. Okay, so the first one is easy. Community organization theory. That's the name of it. This involves the process of involving and activating members of a community or subgroup, right? So we're going to identify a common problem or goal, to mobilize resources, and then implement strategies and evaluate their efforts. So this has a real grassroots approach rather than an effort initiated and conducted by health professionals. So a community organizing theory, this may not just be, health professionals. This may be a group of a community that notices there's a problem, an issue, and so they want to see change and get involved. So we have concepts along with this theory too, right? So we have the concept of empowerment, which is that process of gaining mastery and power over oneself or one's community to produce change. That community competence, which is looking at the community's ability to engage in effective problem solving. Participation relevance, We're looking at the learner, which is the community in this scenario. So more than just one individual person, right, that are active in participation, and their work should start where the people are, right? So that's that grassroots. They have that issue selection. They're going to identify winnable, simple, and specific concerns as a focus of action, right? So they're going to look at those specific issues and concerns and keep them simple. And we talk about that with individual patients too, right? We got to keep it simple sometimes, which can be a challenge when you're going to school and just as a dental hygienist and oral health care provider in general, because you see all the things. You've analyzed it all. You see all the things that can change. But we can't give our patients or a community just a list of things they have to do, because then we're not setting them up to be to be winning, right? We're setting them up for failure, which then we also feel like we've failed. And then critical consciousness is the last concept. And this is developing the understanding of root causes of the problem, right? Because we got to know what's going on. So an oral health example for community organization theory. If you think of the role of a church pastor and a congregation in oral health promotion, right? We've talked about how like religious communities and things can be very helpful in a community dental health setting because it's a place where people come together already. So the church members, right, in the community organization, this isn't something that's necessarily began with a health provider. They notice, the church members do, that many of the elderly people have stopped coming to church suppers because they've lost their teeth and are embarrassed to eat in public, right? Or maybe it's hard for them to eat what's been served, so they don't come. So they engage with dental and dental hygiene students to work together to assess each elderly person's needs, right? So they're going to do an assessment and to fabricate and fit the dentures, right? So they're going to work with some dental and dental hygiene students to help out this community's population. And then gradually, that's going to help the elderly people become comfortable eating and speaking with their dentures, and then resume their attendance at their church suppers. Right? So again, the important thing with community organization theory is to remember that this is initiated not by healthcare providers. This is something that non-healthcare care providers have noticed, right? And then they start to take action, which then involves somebody like dentists and dental hygienists, because they are the experts in the problem that they were seeing. So at the community level, we also have the diffusion of innovations theory. And this helps us assess how new ideas, products, or services spread within a society or to other groups. Right? So during the assessment, attention is directed to the characteristics of the innovation, the communication channels, and the social systems. So they're looking at new ideas, products, and services and how they spread within a society or to other groups. So when we're looking at the different concepts of the diffusion of innovation theory, we have relative advantage, which is the degree to which an innovation is seen as better than the idea, practice, program, or product it replaces. Right? So how is this product seen, right? Is it viewed as better? And how much better? Compatibility is how consistent the innovation is with values, habits, experience, and needs of potential adopters. Complexity is how difficult the innovation is to understand or use. Trialability is the extent to which one can experiment with the innovation before a commitment to adopt is required, right? So Do we have free samples? We're going to do some introductory sessions, right? Maybe a money back guarantee. And then the observability is the extent to which the innovation provides tangible or visible results, right? So often as individuals and communities, we like to be able to see that something's doing something, right? And if we are the creators of a new innovation or product, we want those results to be visible and we want to get that feedback, right? Or publicity. So an oral health example for the diffusion of innovations theory is if we look at something like dental sealants. Okay, so dental sealants to us just seem like the norm. Like this is just what we do and that's the way it's been. But dental sealants haven't always been that way. And there's still a struggle, especially in private practice settings, for more widespread acceptance, use, and implementation of sealants. So the adoption of dental sealants by practitioners proceeded slowly, especially in the beginning. It was adopted more quickly in public health settings and clinics, right, where a clinical need for the effective caries prevention measurements and strong advocacy for the procedure were present. So in public health clinics, dental sealants, like they saw the benefit. They could visually see that, right, much faster than in some of the private settings. Now, the adoption occurred much more slowly in private offices. And sometimes it still is moving slower in private office settings than it does in public health settings. And some of that is just because in public health settings, we're also viewing and assessing the entire community. Where in private offices, we don't always have the time, the resources, or the desire to look at and collect data and information specifically on the population we serve. But another side of it too is that private offices tend to have patients that had lower caries rates, right? So the need for sealants was not viewed as high. And then in the beginning, some insurance companies did not reimburse. That is not that common anymore, but in the beginning it was. And then practitioners, dentists in particular, they often are kind of set in their ways, right? They learn a certain theory, they learn a certain skill, and they want to keep doing what they want to do. And so sometimes it can be hard for us as healthcare providers and practitioners to change and try something new. So over time, the caries rates in occlusal surfaces declined dramatically in children who received regular care and sealants at clinics, right? So in the clinics where dental sealants had been adopted and were being used more readily, they saw a decline in caries rates, even though those populations may have had a higher risk of caries to start with. But in the clinics where the sealants were not applied, the caries rates remained the same, right? So they didn't get that benefit of a decrease. And this was true in private and public settings. So that helped, right, give stronger efficacy on dental sealants. And then there were major educational efforts and policy changes, especially on reimbursement. Advocacy efforts were used to change those attitudes and patterns of practice, right? Especially in the private sector, because we talked about how they were much slower at accepting the adoption of sealants than in public settings. And this resulted in reduced dental caries rates in children across the board. Right? And this is why dental sealants are more the norm now. But you will notice, depending on populations you work with, even certain parts of the same town that you live in, that some practices are more inclined to do things like dental sealants than others. right? And you will hear different views and theories on that. So it's important for us as our own healthcare providers, right, to know the facts and also speak up with what we know and use those facts, right, the research and the stats. Because it's really easy to get caught up in those kind of like day-to-day like experiences, which those are important too. But we also have to remember that individual experiences don't mean general population experiences all the time. But they might open our eyes to something we need to research or look more into, right? So then we also have the organizational change or stage theory. And this is at the community level also. And this is when organizations pass through a series of 4 stages as they initiate change. Okay, so the stage theory is looking at 4 stages. So when we're looking at the stage theory, we are going to look first at that definition of problem, right? So we're recognizing the problem, we're analyzing it, and we're looking at solutions and evaluation. Then we have that initiation of action. We'll look at policy or directive, something that we're going to formulate. We're going to look at resources for beginning change. Then we're going to implement that change, right? The innovation is going to be implemented. It's going to take action. We're going to do it. Then we have that institutionalization of change, right? So we found the problem, we analyzed it, we thought about and made a plan for the action. We actually did the action, we did the implementation, and now we're looking at the institutionalization of change, right? Policy or program becomes entrenched in the organization, right? It just becomes the norm. And then new goals and values are internalized, right? So that's just the way it is now, right? We've created that change, and it's like, well, this is just how it is because it's entrenched and those values are internalized, right? So if we're going to look at an oral health example in the stage theory, we're going to consider a situation in which health educators asked the cafeteria staff in a hospital to offer healthier foods. Right, so we had a number of stages that were involved in instituting the change. First, we noticed there was a lack of healthy food. Then we came up with a plan, which was to ask the cafeteria staff to offer healthier foods. Hopefully we gave them a little more guidance than just saying healthier foods, right? And then by having that healthier foods available that we asked for, eventually a larger percentage of the employees began to select the new food options, right? Which led to them eating healthier lunches. So one thing when we look at all of these theories to keep in mind is that we don't always necessarily just use one, right? So we can use a variation of theories combined whenever we're promoting health. So we may use more than 2, right? And this helps give us that enhanced ecological dimension so we can be more effective and create more successful, comprehensive community oral health care programs. Right, so we don't just have to use one and that's it. So when we're looking at these theories, right, we have different knowledge and strategies that need to assess and change behaviors and systems. Right, so we're going to look at factors that consider the risk for development of oral diseases, factors that can be modified through prevention efforts at that primary, secondary, and tertiary levels. Then we're going to look at assessing a person's risk for development of oral diseases and other health problems. We're going to look at the scientific evidence for especially if we're looking at implementing, right, different preventive measures. We want to make sure that they're effective, and that the evidence is there, right, that shows they're going to work. They're going to be beneficial. And then we have categories of interventions that we're going to look at, those categories that yield the desired impact, right? So we want to look and see if we're going to have personal behaviors, programs, societal and environmental modifications and policies. Like, what are we actually looking to impact? We want to make sure that there's effective oral, written, and electronic communication skills, appropriate and effective communication methods and channels, ways in which innovations are diffused, and ways of bringing about organizational change, right? We're going to look at all those strategies. Ways to motivate people to access services and to come back. And then the structure of various healthcare systems and community-based organizations, right? So we're going to evaluate some of those structures in general. So whenever we're talking about health promotion, we got to make sure that we can communicate that, right? So health information technology is a big deal. And it's important, and we can't ignore it whenever we're talking about, especially whenever we're talking about community health, but even on individual health basis, right? We've got to be able to communicate well with our patients and in a way that they are going to communicate with us. So health communication really encompasses the study and use of communication strategies to inform and influence individual and community decisions that enhance health. Right? And this can be challenging because we don't all use the same forms of communication. This can be different for communities as a whole. It can be different for individuals. And whenever I talk about communities, like sometimes that can be the community as a whole, the population you're looking at, right? But then that can also vary by communities within your population, right? By age, generational differences, just access, variations to access, right? We can't just assume always that everybody has an email address or that everyone has access to the internet. Those are big ones whenever it comes to health information technology. Right, so we can't make assumptions that individuals have the same access or the same communication kind of strategies that we do individually. So that's where we have to look in to see what people are using. So as I mentioned before, health information technology is important because technology and health communication meets our consumers' expectation in today's age of technology. So there are ways that we communicate now with patients that will change along time, the course of your career, the course of my career. And there are ways that we'll communicate that we won't even know exist now, right? So we have to be able to adapt and be flexible and change with those in order to be effective communicators, especially if we are working in a community setting. But there's lots of things that can be challenging too, right? We want to find effective channels. We have to find the right context, the right content, and be able to capture people's attention and motivate them to use health information, right? So that health information technology is really critical and essential to communication these days. And is forever changing, forevermore, and always has been, right? A newspaper ad is probably not going to be the most effective. However, if you are working with a senior groups, right? A lot of them do use electronic things, but you may need to do some health communication through a senior newsletter, whether that's in a digital or a print format, right? So we have to know what people are using. Social marketing, of course, is part of framing health messages. And social marketing is defined by the CDC as the use of marketing principles to influence human behavior to improve health or benefit society. Right? So it's focusing on consumers in relation to marketing health services. And then that can be accomplished by emphasizing the 4 P's of marketing. And the 4 P's are product, right? What are you marketing? The price of the product, the place, and the promotion. So I strongly recommend that you look at table 8-9 on page 218 and read and evaluate a little bit more on some of the specifics, right, of the 4 P's of marketing. So marketing isn't just, when we talk about social marketing, it's not just social media marketing, right? It's just marketing in general to the consumer, and looking at these 4 P's. So here are some vocabulary words that can be helpful when we're thinking about framing health messages, right? So framing health messages relates to how messages are crafted and certain cues are used. So gain framing a message is focusing on what is to be gained by adopting the recommended health behavior, right? What's going to be better? Tailoring health messages relates to making messages meaningful to a specific individual. And a lot of times, some of these things, this is where sometimes we will use like marketing companies to help research and analyze what needs to be done. So, framing health messages, an important message, and we touched on this a little bit earlier, is increased knowledge does not equal behavior change, right? So just word vomiting information to patients doesn't mean that they're actually going to change their behavior, right? We have to find that motivation. And that's true whenever we're talking about individuals, when we're talking about interpersonal, person to person, and when we're talking about a community. So we have to be able to market and engage patients and communities to actually help change behaviors. And the way we engage certain groups and certain populations and certain communities varies. And so it can be really challenging whenever you're talking about a whole community, right? Think about how challenging it is just with one individual patient to figure out what they will engage them or actually help them make meaningful change in their behaviors. It's not easy. So another method for framing health messages is using targeted materials that are intended to reach specific subgroups or populations. Right? So we may be looking at really specific demographics. And if we've done the right analysis and research in figuring out our population, we may be able to hopefully single out certain subgroups within our population, right? And you see this especially across, like, if you've done anything on your phone or your computer, you look something up, and then what do you get? You get targeted ads. So take that same concept, but we're going to think of it in health messaging format, right? So maybe not bombarding somebody with, Christmas ads, or you look at one sweater and then you have a million sweater ads that pop up constantly in your Instagram or whenever you're Googling things and looking stuff up online. But those targeted materials. So we may not be using algorithms necessarily in framing health messages, but we're targeting materials to certain subgroups. We may also use personalized messages, right? And the internet promotes individualization by allowing people to search for and discuss information that applies to their particular situation or answers their specific questions. However, it's really difficult for consumers to determine what is valid. And if you've ever had an anti-fluoride patient, you know how difficult that conversation can be, right? Or a patient that absolutely refuses x-rays. It can be really frustrating because they've done their own research, right? Even though they didn't go to school like you did, they haven't read all the real research, right? They're going off of what their neighbor Sandy said or what Sandy told them on Facebook. And so, those personalized messages can be difficult for consumers to determine, like, okay, well, is this like a legit message or is this, just someone's opinion or some random experience? And then you start to realize maybe your neighbor Sandy is a little crazy and she doesn't know what she's talking about, right? But it can be really hard as a consumer to determine that validity. The most effective way to reach individuals is to increase their knowledge or to change behavior is to tailor messages, right? And you all try to do this with your individual patients. And I know it can be challenging with individual patients, and it can be equally, if not more challenging with communities, right? Because we often have to do not just one-on-one conversations, we have to figure out a whole entire community. But it can be done. So when we're selecting and evaluating those communication formats for different audiences, we want to make sure that language and graphics are inclusive, that they don't promote stereotypes, and that they're easy to understand for any reader or listener, right? So we want them to be simple, easy to understand, and they have to be catchy, especially these days. They've got to catch your attention. We are bombarded with information all the time. So a good way to do that is consumer-oriented communication. So we can do hands-on, interactive, multimedia formats. These are usually more effective for retaining knowledge than just simply reading or listening to a message. But again, we got to keep it simple, and you got to keep it short, and you got to keep it sweet. So when we talk about their making something in a format, right, that's at the right level of knowledge also for a patient, that's where that health literacy comes into. And if you remember way back whenever we were talking about Healthy People 2030 the first time, this round is the first time that they initiated the personal health literacy and organizational health literacy, right? So individuals and then organizations in that health literacy and improving that health literacy. So it's important whenever we're talking to individual patients or if we're doing a presentation that we are aware of the health literacy of our audience, whether it's one person, it's 10 people, it's 100 people, 1,000 people, thousands of people. We need to make sure that we know their health literacy level. When we're talking on an individual basis, a lot of times we can assess that while we're talking to a patient, right? And you may adapt as you're going in your conversation. When we're talking about communities, that usually takes a little more research and evaluation, right? Because we're looking at a whole community. So communication should also be culturally sensitive and linguistically competent. So if you remember back whenever we did, we worked some with that translation app, the Google Translate, is that not everything just translates straight across, right? There's words in the English language that don't exist in other languages. There's words in other languages that don't exist in the English language and across all languages. So that can be a challenge, right? If we're trying to make something, especially if, maybe we're doing a pamphlet or something and we want it to be in multiple languages for the community that we're serving. It's not often just straight across, switch from one language to the other. But sometimes we do the best that we can with what we have also, right? So we want to make sure, though, especially if we have products that are in written form, that they're linguistically competent, that they make sense. We also want to make sure that we have effective interventions that are high intensity. They're theory-based, right? We talked about those theories. And when you read through those theories, I promise you, as time goes on especially, and you have some of those theories in the back of your head, you will see some of those theory processes and those concepts happening as you talk to individual patients. We also want to pilot test our communication, right? Do a run through. Test it out. See how it goes. We want to emphasize that skill building, which you do that with demonstrations with your patient. And then it's also really helpful that they're delivered by a health professional, right? So these are methods that they've shown create effective interventions. So, like we do in everything, we have a planning process, right? How are we going to know what's the best theory to look into? What theory are we falling into? What culturally sensitive material do we need to do? What maybe languages do we need to be in? What do we need to focus on? What does the community need? So what can help us with that is a needs assessment. And that is actually where we look at the community as a whole, which can help us determine what we need to focus on, how we can focus on it, what needs to be implemented, what's effective, what hasn't been effective, right? And then we get to develop a health promotion or health communication plan before we start, right? And again, you do this every day when you go through and you do your assessment, and then you come up with a plan, right? So we're just taking that on a bigger scale. We want to make sure that we have objectives if we're creating a plan, activities, so we know what we're doing, key messages, right? That helps with our messaging, keeps us focused. The target audiences, who are we talking to? Who are we communicating with? Timelines, those resources that are needed or available. Sometimes we have to use the resources that we have. The responsible parties, who's going to be doing what, who's going to be receiving the education, evaluation methods. How are we going to know if what we're doing is worthwhile? How are we going to measure that? And then what do we anticipate is going to happen, right? So when we're talking about those evaluation, there's different ways that we can help evaluate things. Formats and channels, materials, right? This is all critical to document so that we can keep track of things. Evaluation can occur during and after educational interventions, right? So we can do this throughout. A lot of times evaluation will happen at the end. So when we are determining the effectiveness of interventions, we have some guiding principles, right? Has the intervention achieved the desired results? Why or why not? Should this intervention be continued in its future form? Maybe we need to change it if it didn't achieve its desired results, right? What messages or activities produce the best results? How can the intervention be improved? Can it be replicated successfully in other settings? And what are the sources? Like people, money, and materials that were used reasonable and cost effective, right? Especially whenever we're looking at an entire community source. And that also comes back to that replication, right? Can we replicate it easily and reasonably in a cost effective manner? So here in box 3 are some samples of simple evaluation mechanisms to look at the effectiveness of our communication, formats, and our materials, right? We can ask the patient questions, 5 questions about their knowledge and attitudes towards whatever we're looking at. In this case, we're talking about sealants. We can follow up 2 months later to determine if something is still being used. We can survey after initiating an oral health injury or mouthguard campaign, right? This is an example. So we can survey later to see what people thought. Is it something that they would do? We can record, if we're talking about like social media, how many tweets are posted about a perinatal oral health campaign? How many something was retweeted or shared or liked, right? What key messages were more popular? And then in that instance, you have to evaluate then too, like, is it the message? Is it the formatting? Like, what are the similarities? And then a questionnaire or an interview is always helpful after an intervention or a conversation, right? So these are just some examples of some evaluation mechanisms. And it gives specific examples for specific programs, but you can see how these can be utilized, especially whenever you are creating your own program, because you're going to need a way to evaluate your effectiveness in some way, which often is in the form of a questionnaire. So presentations are often given from one health professional to another, right? And it's intended to be thought-provoking information that's given in a short period of time in a clear, concise, and visually appealing format. We're going to talk about some of those formats. So again, we have some guiding principles, those 5 questions whenever we're selecting a topic and format. These are very helpful whenever we're thinking of next semester. Who will be the audience? How large is the audience? What is their level of knowledge or interest in the topic? Do they care? What questions might they ask, right? Am I going to be prepared? Will I be able to learn new information related to my topic from some members of the audience? Do you ever learn something new from your patients? I do all the time. How much time will I need to cover my key points? That's where that pilot testing or a practice run is helpful. What audio-visual materials will most enhance my key points, right? What's going to help keep my audience engaged? So we're talking specifically here about presentations to health professionals, but these presentations, especially the sequence, is not necessarily just to health professionals, right? You can take this concept if you're thinking about doing a presentation at a school or maybe at a daycare center where your kids go or family members go to, right? So this sequence can be used in a lot of ways. You usually have a little bit of an introduction and some background, methods and materials, your findings, results, or key points, discussion and significance, summary and conclusions. So this is very broad. When I'm talking about using this sequence in a sense of talking with people that are not healthcare professionals, right? We're going to use this sequence in a broad sense. And next semester, we'll get more practice with this. But here are some examples whenever we're talking about health professionals, right? So you're presenting to your peers. So poster presentation is very common. Often the time that is spent doing the presentation itself is 1 to 2 hours. Now this is usually in a setting where there's like multiple poster presentations, and often these can be really big. ADHA has poster presentations at their annual session every year, and they are on like big boards. So these are big posters. And the presenters are usually standing there next to their display. The display is usually very colorful. It has lots of graphs. It has some information, right? It kind of follows this flow of giving some introduction, methods, and materials, but everything is really simple, right? It's broken down into just the bare minimum. Sometimes you will have your audience can vary. right? In a scenario like this, you're just standing and kind of waiting for people to show up and want to talk about what you've got and what's been going on. Some people will just want to look, and others may want to sit and talk to you for hours and hours and hours if they could. But we've got lots of color going on, and you are there usually as a presenter. The posters often are up when you are not there also, so people can look at them and get an idea before or after the poster presentation officially has ended. So some of the benefits is that you have an opportunity to discuss the topic, share ideas, and acquire additional ideas, right? Talk with people. But a limitation can be unpredictable attendance, right? You may have a lot of people, you may not have a lot of people. And it's not appropriate for topics that require videos or other types of media because it is literally a poster. So with your poster presentations, there's some tips and things to consider, right? So if you're thinking of doing something or using something like a poster type of format for a presentation, these are good tips to take into consideration. And as we work on some of your presentations, you may find that some of them are going to be, we will take some of these concepts and adjust them if we are not working with other health professionals, right? So presentation for an oral paper, you will all get to do something kind of similar to this. I know you've done some of it in Miss Griggs' class for perio. And then whenever you do your oral presentation of your perio patient, it's going to be similar concept to this. So this is usually about 10 to 15 minutes, right? And this also includes time for questions at the end. Using notes, accompanied often by audio visuals, PowerPoint slides, short videos. Those things can be very helpful, right? So a lot of times you have maybe more than 30 people, but it's suitable for hundreds of people if you need to. You can also have less than 30 people for a presentation of an oral paper. You're not just reading your paper though, right? You're hitting the key points. Benefits is that you can do a large group. You can speak from printed notes or directly from slide notes on your computer. But some of the limitations, right, we've experienced this in class, is the lighting can be fairly dark, interaction with the audience is limited, and then there's a vast array of knowledge in the audience. So it can be hard to know, your level, especially if you're getting into the hundreds of people. You may have some people that know all kinds of stuff about your topic, and you may have members of your audience that know very little to none. So that can be a challenge because you're trying to meet all of those health literacy levels. So here are some tips, right? And one of the biggest ones is do not read the paper word for word. I did something similar to this when I did my thesis. It was longer than 10 to 15 minutes, but not bad. I think I had to keep it within 30 minutes. But that was called a thesis defense. But basically, I was hitting the high points, and then I had to answer questions afterwards, which was nerve-wracking, but I made it through, and I remembered and knew a lot more than I thought. And I also had my notes if I needed to refer to something. But I did practice it a lot before I got up there and did it. So then we also have a roundtable discussion, right? This is usually timed out in like half an hour to an hour's type of time frame. And sometimes it can be repeated, right? So you might do it with more than one group. This can often be in conjunction with like an oral presentation and discussion, right? So this could even happen after maybe the presentation of a paper, right? But you want a smaller audience size. So you're going to have 8 to 10 people, but you could have multiple groups of 8 to 10 people. A lot of times you have handouts or materials or products. Sometimes you'll have like in a group, if you have bigger groups, you may have smaller groups within that larger group. but the presenter might be guiding everyone through some of the same conversations, right? This is a really interactive format for discussion. Participants can get to know each other and share more information with the whole table. And it's good for those conversational topics or new ideas. But it does often limit the number of people that hear the topic. Again, here are some notes for that. And you need to have facilitation skills, right? And the ability to refocus groups if the discussion gets off track or gets monopolized by one individual, which can be the most challenging part sometimes if you are the facilitator, is how do you gently and kindly cut someone off and not get off track yourself. So then we have web-based presentations, which is becoming more and more common and desirable. And I think for most of you throughout your career, like you will do lots of web-based. You may not be the presenter, but you all could be and talk about something that is meaningful to you or something that you've helped research or help facilitate or something you've implemented in the practice that you own or that you work for. But a lot of times, again, this is 30 to 60 minutes. It can be a live audio stream, right, in a web-based presentation. Sometimes web-based presentations will be recorded so that you can also reach larger audiences because they can then listen to the recording later. This is a similar example to a web-based presentation, right? But this is a recording. It can be limited. This one's kind of funny because in the example in the book, it talks about the size of the audience. And it says limited to 100 phone lines, which doesn't even make sense whenever you're talking about a web-based presentation. But you could have software limitations, right? So I know at the state level for CODHA, we've done some web stuff and we've had to upgrade like our Zoom account so that we could have like 500 people on because 100 wasn't enough, right? So those can be limitations. Not really phone lines so much, but more applications that we use. Slides, right? There are so many different kinds of audio visuals, whether you're doing a web-based presentation these days or you're doing just kind of a stand up in front of people presentation, roundtable. Like PowerPoint is very common because it's easy and user friendly, but there are so many different things out there. So you can really get creative. But you can reach a larger audience, right? But there isn't always great interaction, especially if it's recorded, but especially even if it's not recorded, interaction is a little bit more challenging. And then you can get unintended noise or line interferences, right, if people aren't muted. Nowadays, though, a lot of times that will happen in web-based presentations is that you will have a moderator that works with you. And so they're going to help mute people if they come unmuted, help answer questions, and help facilitate some of that because it is difficult when you are the presenter. A lot of times you can't really see your audience, but they can see you sometimes. So you need a facilitator that's going to help you with that. And of course, always doing a run through and a pilot run and then making sure that you don't have any sources of noise. So as always, we're going to evaluate, right? How did it go? And we talked about different ways that we can get that feedback, right? Questionnaires are really common. I mean, if we were in person, I would ask all of you how many times you've been asked to fill out a questionnaire after you did something as basic as talk to AT&T about your cell phone bill or something, right? They always want to know if you'll ask a questionnaire. That's what they're doing too. They're trying to assess maybe how well they've done something, how poorly they've done something, and what we can improve upon and what has worked, right? It's important to know what works too. We want to focus on some of those positives. So another thing that's helpful and important whenever we're talking about program development and communication, and that health promotion, right, is that we're working on our professional development. And when you get out of school, a lot of that becomes a little more fun. Sometimes you just will take a course or you'll participate in something because you know that you need some CE requirements for your licensure. But I really encourage you to find sources of professional development that you actually enjoy and get something out of, right? And a lot of times what you'll find is that the networking that comes along with going to continuing education classes or seminars and things are what help with the longevity of your career and keep us from getting bored or stale in our positions, and just helps keep us to be learners and growing in our careers and as health professionals, because I promise you, you won't realize it until it happens, but things change and things sometimes change fast. But it's important for us to be able to adapt and change as things change, right? And so dental hygienists often, in my experience, tend to be pretty good at that. But we also like the networking side a lot of times. Like we like spending time with other people that share our interests in our careers. And we have fun whenever we get together. So make sure that you're, reading those reliable information, whether that's a digital magazine, that's a journal, books on different topics. And you don't have to focus on just oral health, right? You can help learn new things that are impacting oral health or other diseases that are affected by oral health in a positive or a negative way. So, as always, if you have questions, I know this is a recording, but email, text me, let me know if you need any other information or if something doesn't make sense. But I thought these were fun too. Did you know that dogs can smell your feelings? Which is pretty amazing. And I know my dog in the past has sensed my feelings, at least. Maybe he smelled my feelings because I was really nervous and he was nervous. And that koalas are even more lazy than cats. And did you also know that cats use their whiskers as feelers? I think I kind of knew that. That was one of those, I've just inferred that knowledge. I've just gained it and I didn't even know it. And that cats also love to sleep. Sometimes I think maybe I should be a cat because I love to sleep too. And I love a nap. All right. And that is the end of chapter 8.